This is the first of many lecture videos that will cover all the content about respiratory and ENT. It is a huge topic. We'll begin with the differences between children and adults, but you have to answer these questions. What does the anatomy of a child, or actually how does the anatomy of a child affect oxygenation? How will the child be able to compensate when the alveoli are obstructed? Do children have as much reserve as adults? When we're in class, we're going to discuss the respiratory disorders in terms of contrast and compare. What do they have in common with adults and what are different? What respiratory disorders are more common in children, but we rarely see in adults? And very important to your practice, what are the important assessments to make for respiratory and ENT disorders? When we do a focused assessment on the respiratory system, you begin with your observation. You walk into the room or you see a child come up to the window and your eyes should already be focusing on what does this kid look like? Are they alert and playful, or they could be sleeping, in which case they won't be moving. But if they're awake and they're not interacting appropriately, you would automatically know this child is in trouble. So look at their color, notice any kind of cough that they may have, and how do they respond to stimuli. You need to focus on their vital signs, and with a respiratory disorder, in particular, we're looking at their heart rate, their respiratory rate, as well as their temperature. What kind of effort are they using to be able to get in enough air? How deep are they having to breathe? What is the rhythm of their respirations? You can do all of this without even touching the child, other than the vital signs. Look at their pulse ox, and finally, we're going to put the stethoscope on the child's chest, and we're looking for these adventitious sounds. You're also going to assess whether or not, or the breath sounds actually, are absent or are they diminished. Listed below are the classic signs of respiratory distress that can lead to respiratory failure in children, and you need to be able to recognize these and immediately begin interventions to avert a disaster. We're going to talk about this more in class, but you need to know all of these. Make sure you watch the DVD on red flags related to respiratory care. I don't know the exact title, but it's an excellent video or DVD, and it will show you what these kids look like when they're in trouble. So when you look at this kid's face, he has an anxious expression. He's sort of staring out, not really fearful of the provider, but he's fearful because he can't get in enough oxygen. Here's an example of respiratory retractions, and these retractions can be intercostal, subcostal, suprasternal, substernal. And this is a child who is in profound respiratory distress. The only way that he is able to expand his lungs enough to get air in is to sit in a tripod position. There's nasal flaring, there's sternal retractions. He's using accessory muscles. This child would be tachypnic, and you would notice that he is cyanotic if it was real. This child needs to be put in front of a provider immediately. So our respiratory care priorities are your ABCs. Assess early and often. When you do an intervention, you need to reassess. Monitor this child for apneic events, especially in the young infants. Look at their O2 sats. Look at the cardiac respiratory monitor. And then with some, you'll also be monitoring their CO2 levels. Make sure that you set your cardiorespiratory alarm limits appropriately for the child. And if it's not working, troubleshoot it, but always make sure you look at your child first. When it's alarming, it could be the child or it could be the machine, but you assess your child first. And then if the child is going downhill, be prepared to assist with interventions that require emergency equipment. When you need help, get it. Don't forget, we have rapid response. This slide depicts something we discussed in Skills Lab about correct positioning when we need to perform CPR. You don't want to hyperextend the infant's head because you'll obstruct their airway. Review what to do when there's foreign body aspiration, infant versus child. You all have a CPR card, and this is a part of CPR. Here is a list of the variety of respiratory and ENT disorders that we're going to cover in this module. So there's congenital anomalies and disorders, asthma, pneumonia, cystic fibrosis, which is one of the issues that primarily affects children, but now our interventions are so good, these children are living into adulthood, so you actually may run into these kids as they are adults. We have the allergic rhinitis and sinusitis, upper respiratory infection, which is extremely common, the variety of pharyngitis as well as tonsillitis. We have our croup syndromes, that includes laryngotracheobronchitis. What's not listed here is epiglottitis, which is very important. And then we have bronchitis, bronchiolitis, otitis, and foreign body aspiration. Listed here are the common nursing diagnoses that are pertinent to respiratory and ENT disorders in children. So clip this out or just refer back to it when you're doing your care plans. We'll briefly discuss SIDS and ALT. So SIDS is sudden infant death syndrome. ALT is apparent life-threatening event. So that's a near SIDS. We have different types of apnea. We have central apnea, apnea of prematurity, obstructive apnea, and sometimes the apnea is mixed. So when we have central apnea, there is an absence of respiratory effort and air movement, and the physicians will investigate why does this child have it. Obstructive apnea, something is in the airway, and they're trying to make efforts, but there's no movement of air, and you're not going to hear any breath sounds. If it's only a partial obstruction, you're going to hear the stridor. And then, of course, mixed can be a combination of either. When we have apnea of prematurity, this is due to immaturity in the child, and they're not able to coordinate breathing, sucking, and swallowing. This is very common in the NICU. We have a profound reduction in sudden infant death because of the Back to Sleep program, and this has been implemented worldwide. For an apparent life-threatening event, these children all of a sudden go limp. Many times it's as they're falling asleep or while feeding. The parent just notices that the child has become very heavy, different from when they get heavy from sleep. Sometimes they have to initiate CPR. Sometimes they are totally freaked out and they call 911 and the paramedics initiate CPR. But this child looks nearly dead when this occurs. We will admit all of these children for observation for at least a 24-hour period, and they're going to investigate whether or not this child has a cardiac defect, a respiratory defect, or it could be a neuro defect. Sometimes an ALT will occur when a child is septic, and if that's the case, then we're going to go down that pathway to treat it. What's important on your ALTs is you're going to put this child on a cardiorespiratory monitor. You're going to observe for these type of events, initiate interventions if the child quits breathing. And then when this child is discharged, they may need to go home on a home apnea monitor, so you have to teach the parents how to use it and how to respond. They're going to be very nervous. At Chalk, they have a video that they have the parents watch, and then they also need to learn CPR, and it is your job to teach this. So after the parent learns, then you have to get the return demonstration so that we're confident that they'll be able to take care of the child at home. This ends part 1 of respiratory ENT disorders.